Good afternoon to all of you, and very good morning to you, Subadra. Subadra, hope you can hear me. Okay, good morning. Very good morning to you, Subadra.
Good morning.
I warmly welcome Dr. Subadra Wanninayake to this forum today. I also welcome all who have joined with us today for this webinar organized by College of Chemical Pathologists of Sri Lanka. I'm honored to have the privilege of introducing our guest speaker today, Dr. Subadra Wanninayake. She is a consultant in inherited metabolic disease in Queen Elizabeth University Hospital, Birmingham, NHS Foundation Trust, London. Today, Dr. Subadra is going to talk to you about inherited metabolic diseases in adults. Dear Subadra, many thanks for agreeing to share your experience with us today and also allocating your time for us in spite of your busy schedule. We are grateful for your presence here today, Subadra, and I'm sure that this will be a valuable experience for all of the attendees present in this meeting today. Over to you, Subadra. You can start now.
Thank you, Madam, for your kind introduction, and thank you for giving this opportunity to share my experience with you. And I will discuss few things on inherited metabolic disease in adult in coming.
Subadra, I think the volume is a little bit low.
Can you hear now, please?
Okay.
Shall I share my screen with you, please?
Yes.
Can you see my screen, please?
Yes, we can see, but volume should be a little bit.
Sorry.
Others, can you hear, Subadra?
Can you hear now?
Okay.
Yes, we can hear.
Okay.
All right. Okay. Shall I switch on my video, please? Then it will be good.
Yes, then it will be better, no?
It's difficult.
Video is on now.
No, it's all right. Yes. Thank you, Madam, for kind introductions, and thank you for giving this opportunity to discuss on inherited metabolic disease in adult. As you can know, major metabolic pathways are closely integrated with key molecules via complex mechanisms. Inherited metabolic disease is a group of inherited biochemical disease in which specific gene mutation cause abnormal or missing protein that lead to alter functions. The majority are single gene defect that affect enzyme that convert one substrate to another. As you can see, the metabolic block result in disorders that disrupt the synthesis or catabolisms of complex molecule, disorders that lead to acute or progressive accumulations of toxic molecules, or disorders due to deficiency of energy, productions or utilizations in different organs like this. There are over 600 recognized inherited metabolic disease, and the list is growing. Individually, it is rare, but collectively it is quite common. It nearly 1 in 1,000 prevalence. Majority are autosomal recessive and some are X-linked. Disorders in metabolic pathway can be categorized as follows. But to be honest, these are purely for the academic purpose, and I'm not going to discuss in details. So these are subcategories of the main categories. And the disorders in metabolic pathway can be increased in number in adult population because of three main reasons. Many of affected individuals are surviving into adulthood due to early and better treatment, and wide spread of recognitions due to improved diagnostic facilities and great awareness. And lastly, increased recognitions of new cases through the family family pedigrees. And inherited metabolic disease is a challenge because it is manifested in heterogenic way. That means there is a variety of signs and symptoms, and presentations easily can mimic non-genetic or non-metabolic disorders as well, and they are often precipitated with common illnesses.
Excuse me, Subadra, we can hear you better if it is little bit louder. Just check whether your sounds are okay. We can hear you better if it is louder.
Right. Okay. Thank you. I will. Now, can you hear in better?
Yeah. We can hear. Yeah, I think you have to
I
speak
off
louder.
my mics. Then hope signal is all right.
Signals are okay. But if it is little bit louder, it is better. Now I think that it's a little bit louder.
Okay. Okay. That's fine. Thank you. Presentations can be based on two common things: clinical or investigation, based on clinical or based on investigation findings. Clinically, it can be neurological and psychiatric symptoms, chronic fatigue or acute rhabdomyolysis, cardiac manifestation, respiratory signs and symptoms, skeletal abnormalities, genetic symptoms, or general symptoms such as fatigue and fever, or hepatic symptoms or abdominal symptoms and signs, ophthalmological manifestations or hematological, or can be as an emergency admission. And hyperammonemia, homocystinemia, hypoglycemia, metabolic acidosis, and abnormalities of the CSF are recognized abnormal biochemical findings, but hypoglycemia and the metabolic crisis is quite less common than the pediatric population. Or it can be abnormalities in the imaging findings, such as brain MRI and the skeletal X-rays. I think there is a problem in sharing slide. Can you see moving of my side, please?
Yeah, the slide, it is a presentation of IMD is the slide which you are on.
Oh, sorry.
Go to next slide then.
Yeah,
Clinical and biochemical
it is not moving.
Imagine.
Yeah, I tried to move it, but
it's not moving.
It's not moving. Right, it's moving now.
It's moving.
Yeah. Okay. And diagnosis and management of inherited metabolic disease in adult is very important, because most are progressive and the potentially fatal if not treated in a timely manner, and it helps to prevent further complication, clinical impact at adult life, like acute metabolic crisis in pregnancy, and to prevent teratogenic effect. Many can be treated and or improved with treatment, but outcome depends on uh, underlying metabolic defect as well as timing of the initiations of treatment. During adult life, the clinical phase of the some inherited metabolic disease, such as lysosomal storage disease, is changing. The progressions of pathology in the kidney, heart, and or cerebrovascular system become clinically symptomatic, and patient generally die prematurely. Approach to diagnosis to inherited metabolic disease is multidisciplinary teamwork, and high index of clinical suspicions is mandatory, and primary care providers should be aware of unique symptoms and signs or cluster of common signs and symptoms that are suggestive of inherited metabolic disease. If there is any clinical suspicions, the individual should be urgently referred to basic investigations, genetic or metabolic teams, and testing for the specific metabolites. Arriving at the definitive diagnosis is relatively simple. The gold standard is an enzyme assay performed on specimen. In some cases, DNA testing is performed as well. Measurement of the residual enzyme activity in muscle tissue, skin fibroblast, and the blood lymphocyte are the most common diagnostic method in current clinical practice. These samples have their own advantages and disadvantages, such as reliability and sensitivity of the results, and the invasiveness, like muscle biopsy. And immune capture assays for measuring the enzyme activity in dry blood spot is available nowadays. And genotyping is important in genetic counseling and may be of supportive diagnostic value as well. It provides the way of determining whether children of carrier patients are also carriers. And in cases with the family history of disease, prenatal diagnosis may be made by determining enzyme in cultured amniotic cells or chorionic villi biopsies. Management is two types. In acute stage, in certain inherited metabolic disorders, the body has an inability to utilize one of its fuel properly, such as protein, carbohydrate, or fat. Therefore, emergency regime is required in acute stage. When these patients become unwell due to another illness or eat less than normal, they can decompensation very quickly if the right treatment is not started promptly. Inherited metabolic disease require acute regime, that emergency regimes are urea cycle defect, organic acidemias, fatty acid oxidation disorders, glycogen storage disease, type 1 and type 3 with maple syrup urine disease. In routine management, a strict lifelong dietary management is a principal treatment in many cases. It can be the only treatment or used in combinations with drug treatment as well, like in homocystinuria. Other options are supplementary or cofactor therapy, enzyme substitute therapy, enzyme replacement therapy, gene editing, gene therapy, and organ transplantation. In addition, supportive therapies. genetic counseling and family planning method is important. These are the metabolic disease which require dietary treatment. Then regarding the disease-specific treatment, to be effective, disease-specific treatment must directly address underlying cause of the disease and reduce or prevent accumulations of the substrate. There are three types of small molecular therapy. They include enzyme replacement therapy, substrate deprivation therapy, and enzyme enhancement therapy. As you can see, this is one of example actually. You can see infused enzyme. It's like it's difficult to point it out, but I will explain what is happening there. It infused enzyme like alpha-galactosidase A is taken up from the circulation through receptors on the cell surface via receptor-mediated endocytosis. Once inside the cells, the enzyme receptor complex is transferred to the lysosome, where the low pH dissociated this complex and activate enzyme. This activated enzyme can then be catalyze the breakdown of GL3 and receptor recirculate into the cell surface again. Actually, development of enzyme replacement therapy is a complex process like this. It's done in commercially now. Currently, enzyme replacement therapies are available for this disease. It gradually increase in number. Then if we move on to the substrate deprivation therapy, it's this is a one of example drug used for the Gaucher disease actually. It's this the action of this is that it active and specific inhibitors of the glycosyl ceramide synthase. So prevent disease progressions by reductions of the substrate accumulations. Therefore, attenuations of the disease progressions furthermore. Then we can move on to the enzyme enhancement therapy. In this enzyme enhancement therapy, it's a kind of pharmacological improvement. In here, misfold molecule like in middle of this picture is again transformed into the folding shape. Then it prevents leakage through this surface channel, and it go to the Golgi apparatus, and it start its proper actions there. Sorry, it's difficult to point out on my slides. Then non-specific treatment for the neuropathic lysosomal storage disease also available. Recent attempts to treat the neurological form of the lysosomal storage disease, including neural stem cell therapy, mesenchymal stem stem cells therapy, hematopoietic stem cells therapy, and the gene therapy are available. And there are many professional organizations to make sure the diagnosis and treatment of patients with the metabolic disease, and they publish several guidelines regarding how to manage the patient and how we have to approach them in order to get a proper diagnosis. And there is another individual guideline as well, and also some consensus guideline, such as in a newborn pig disease, there is a consensus guidelines in worldwide. Then actually, this inherited metabolic disease is a it's a broad topic. So I will share some case scenarios with you. In this first case, a 26-year-old married woman was referred to a neurologic clinic with new onset grand mal tonic-clonic seizure. She is self-caring and able to do simple daily tasks. She is the second child born to the parents of the non-consanguineous marriage, and there was a history of delayed milestones, mild to moderate learning difficulties, and family history of learning difficulty as well. In general and systemic examination, it was unremarkable, and CT brain and EEG were normal. Then deteriorating epileptic control, even though on drugs, with a coexisting history of the learning difficulty and family history of learning difficulties, lead to considerations of inherited metabolic disease, and plasma and urine amino acid screening was done. This confirmed an elevated plasma phenylalanine concentration and decreased tyrosine concentration. It consists with diagnosis of phenylketonuria. Then phenylalanine restricted diet was started, and at age of 31 years, she had the healthy baby boy. Why is it important to follow a strict diet for pregnancy and PKU? As you can see, high phenylalanine in mother cause even very higher than that phenylalanine in unborn child. An untreated PKU pregnancy can be very damaging for the unborn baby. It can be affect brain development, bone growth, and heart development as well. These data show association between higher maternal phenylalanine level and higher risk of congenital heart disease. In here, no definitive evidence for increased incidence of congenital heart disease if phenylalanine level is less than 600. And approximately 12% of offspring born to the mother with phenylalanine 600 to 1500 have congenital heart disease. That means it's double the general population risk. And the risk increase significantly if diet not started by 8 weeks of pregnancy, and risk increase significantly if phenylalanine level is more than 1,500. In here, high phenylalanine in the mother during pregnancy cause a low IQ in the child. And as you can see from this line with border with the red column, 300 is the safe level for child. Then how to prevent this problem? Actually, we can prevent it by keep mother's blood phenylalanine concentration within the recommended level that's provided by the guideline. It is according to the European PKU guideline 2017, it is 120 to 360 micromoles per liter. And keep as stable as possible, and ideally from before conception is required, and if it is fail, at least before 8 weeks of pregnancy. And good adherence to the treatment lead to excellent outcome for the baby. Then this slide show how we can keep the level with adequate limit, because it need more dietary management and planning of good dietary management with good education as well. In the meantime, it is necessary to monitor the blood level of phenylalanine continuously to keep in adequate level of phenylalanine. It recommended is 2 weeks, 2 times per week actually. And then during this phenylalanine restricted diet, tyrosine can be become low, because tyrosine is a conversion of phenylalanine. So we have to make sure add adequate tyrosine to diet as a supplementary actually. Right here. In this population, in this baby, there is no any restrictions to breastfeed because the child liver can degrade phenylalanine. So it is safe to give the breastfeeding even high concentrations of phenylalanine. And meantime, we have to make sure give the adequate other protein and adequate fluid for the mother to produce enough level of breast milk. Then in this case 2, it is 42-year-old man presented with dyspnea and chest pain. His BP was normal, and ECG shows a sinus rhythm with a Q wave in V1 and AVL. In laboratory findings reveal elevated CKMB, LDH, troponin I, pro-BNP with normal CPK level, and creatinine clearance were normal. There was an abnormal finding on cardiac imaging, and patient treated as myocarditis at this point. But 2 weeks later, readmitted with ventricular tachycardia of 220. Based on atypical evolutions of suspected myocarditis and imaging findings, especially cardiac MRI, Fabry disease was suspected, and there was a corneal abnormality on ophthalmological examination. And then plasma lyso GB3 was high, and leukocyte alpha galactosidase activity was low. Then genetic mutations was positive for the Fabry disease, and comments on enzyme replacement therapy. In here, Fabry disease is characterized by either an absence or deficiency of alpha galactosidase activity. The enzyme substrate GB3 accumulate in a variety of cells type, including capillary endothelium, renal, cardiac, and nerve cells. The first clinical symptoms occur during the childhood or adolescence, and it's include burning pain, originate in the extremities mainly, and fever of unknown origin, and gastrointestinal symptoms such as abdominal cramps and diarrhea. More specific manifestations such as angiokeratoma and asymptomatic corneal opacity usually present in late adolescence. Neurological, cardiac, and renal complications develop in the third or fourth decade usually. Then once patients have a diagnosis of Fabry disease, there is an opportunity to identify their family members, and family screening should be conducted definitely. In this case 3, 31-year-old female presented with severe headache, dysarthria, and right hem paresis, followed by the right side focal myotonic seizure. She was treated for the suspected viral encephalitis at that time. And after 2 months, there was a radiological proven pulmonary embolism. In the following year, readmitted with increased frequency of headache, and MRI and MRA head scan was consisted with sagittal sinus venous thrombosis. Initial basic thrombophilic screening was negative, but subsequent investigations showed elevated total homocysteine. It was more than 350 micromoles per liter with normal plasma folate and methyl malonic acid. On ophthalmological screening, confirmed bilateral left lens subluxation at that time, and then CBS deficiency was confirmed by genetic analysis. Uh, as that time, this patient was pyridoxine partially responsive. Beton was started with pyridoxine. Since treatment for the homocystinuria commenced, she has had no further thrombotic event. As you can see, Beton convert homocysteine to methionine in non-enzymatic pathway. Actually, you can see it's on right side of this figure. Then in case 4, 34-year-old primary gravida presented with amniotic odor from mouth and having a fainting attack. It's probably seizure. On ultrasound examination, there was intrauterine pregnancy, but no heart sounds. So dilatation and curettage was done, and because of ammonia odor, plasma ammonia was done, and it was high, and uric acid in the urine was high with low citrulline in the plasma samples. Then genetic analysis confirm OTC heterozygote enzyme deficiency. Then spontaneous single pregnancy was detected 5 months after start of treatment. It was accepted that follow-up by the multidisciplinary team is a good way of managing the patient with OTC. So gynecology, the consultant gynecologist, perinatologist, and the metabolic team manage this patient as as a team, and they agree to continue arginine, ornithine, lysine, amino acid complex with the sodium phenyl butyrate during this pregnancy. And then prenatal diagnosis, imaging studies, and the plasma ammonia level measurement were done accordingly. And at 39 weeks, the baby girl was delivered by lower segment cesarean section. And after delivery, follow-up at postpartum period in terms of clinical findings of the hyperammonemia, the symptoms such as anorexia, vomiting, lethargy, respiratory alkalosis, tremor, the hypothermia or epileptic attack. Intravenous arginine kept available in order to use on the hyperammonemic seizure, but luckily no symptoms required emergency regime for this patient, and mother and baby did not require ICU care after delivery. And on the baby, no mutation was found in OTC gene locus by genomic amplification processed by the PCR. This is an inheritance of X-linked recessive disorder, and explain of this possibility is very important during counseling for the pregnant woman. Female relatives of the patient should be checked for the heterozygote inheritant of the OTC deficiency because they can be uh, in asymptomatic state. Then in case 5, a 54-year-old man presented with a lifelong history of the fatigability, and it was on exertions. As a child, had experience of difficulty going up a hill, and he's lagged behind when he went out for a walk with friends, and repeated medical consultations was unable to provide an explanations for these symptoms, it adding to his unhappiness and resulting in depression. Sensations of his leg become stiff after walking for a while and relieved by rest, and it was if he was in hungry and reduced after meal, and there is no fluctuation in symptoms during time of the day, and there is no family history of the neuromuscular disease as well, and drug and substances abuse were unremarkable. Physical examination also was unremarkable, and then CK and LDH level were high, and there was no hemoglobinuria. At that time, screening for autoimmune disease was negative. According to the clinical scenario, the inherited metabolic disease was suspected, and needle electromyography was done. Its findings were normal at rest, but upon voluntary effort, show a myopathic pattern characteristic. Characterized by reduced durations and amplitude, and increased recruitment of the potential short polyphasic motor unit in the bicep and deltoid muscles. His sensory nerve conduction tests were normal, and muscle biopsy stain for glycogen show sarcomeal accumulations of lake of glycogen, and enzyme histochemistry completely negative for myophosphorylase, and genetic study confirm the diagnosis of McArdle syndrome, DSD type 5. As a management, advised to ensure sufficient blood glucose continuously during the daytime, and it is advised, it can be achieved by adapting a diet with the high proportions of carbohydrate and low proportions of fat, and ingestions of simple carbohydrate such as glucose and fructose approximately 5 minutes before engaging in the strenuous exercise such as physical education is recommended, and meantime very intense exercise are strongly discouraged for this patient. That's all. Thank you. I'm happy to give some more information if you need.
Thank you, Subadra, for sharing your experience as an inherited metabolic disease management team member of Queen Elizabeth University Hospital, Birmingham, London. I think our trainees and consultants who have joined with us today, they may have their doubts. They can ask your experience. You all can ask from Subadra her experience there, what she's doing there and all. Subadra, in your country, what are the inherited metabolic disease screen as a in inborn babies? What are the things that what are the screening tests that they are doing? For what diseases they screen?
Actually, it's there is a list of investigations. It include thyroid and other than that some metabolic disease. It's include PKU and some MSUD as well. And to be honest, I can't remember the exact list, but it's nearly 7. Yeah, it's nearly 7.
In your hospital, in your section, that in your department, you all follow up the patients with those detected at inborn, or the later coming later with the complications when they come, you all follow up.
No, there are two types of There are two types of patients in our unit. Some come from the pediatric team. We take the patients during transitional clinic. And another patient group is we diagnose at adult life. We follow the both patients actually, but the patients who followed up in our unit is more than 16 years old. It's mainly.
So there is a question in the chat box. Can you just see that question?
All right. Okay. Give me a chance. Actually, for the McArdle, there is a place for the ischemic forearm test, but
can you just tell the question what she has asked?
Sorry. In this, the ask what is the place of ischemic foramen test? Is it commonly done there?
Okay.
Yeah, it's available in some centers, but it's a bit it's painful for the patient. So in my center it is not usually done, but sometimes yes, it's done. But there is the place they perform foramic tests as well.
I think Gaya is with us. Gaya? Okay. Anyway, Subadra, all most of the consultants, they are doing exam meeting today, and I think they may can't talk, but they may have listened to you. Anyway, any further questions? Anyway, I'm going to invite Dr. Dilanthi, H.W. Dilanthi. She is our Joint Secretary to CCPSL for giving the closing remarks and the words of thanking for Subadra. Dilanthi, over to you.
Yeah, thank you, Dr. Kisali. I hope that you all can hear me. Okay, so first of all, let me thank Dr. Subadra Wanninayake, Fellow in Inherited Metabolic Diseases, Queen Elizabeth Hospital, University Hospital, Birmingham, NHS Foundation Trust, for delivering this informative and very interesting lecture amidst a busy schedule. So thank you, Dr. Subadra, for the support given, and we hope that you will be involved in future activities of the college as well to support us. Thank you very much again. And the participants, we have a considerable number of participants, and some of them are joining from the centers as well. So the number might be more than this. So I would like to thank all the participants for helping, for assisting us to make this event a success, and those who were interactive with the questions, and thank you for that also, to make this session a very interactive one. And we hope to meet you with another webinar like this, an interesting webinar like this in next month. Until then, wish you, and I hope, Dr. Kisali, are you going to again?
I think we can end the session. Thank you,
Then again,
Subadra, again.
yes,
And
we are
I
going to
think
conclude
we
the
can
session
have
with-
another interesting lecture from you next year. Thank you. Thank you, Subadra.
Thank you. Thank you, Dr. Kisali and all the team.